Welcome to the Explainer. Let's jump right into this masterclass because today we are mapping highly specific structural, mechanical, and pathological joint conditions to their exact ICD-10 CM codes. Now, as an orthopedic coding educator, I know firsthand that the musculoskeletal chapter is notoriously dense. Deciphering those messy, complex operative notes, yeah, it can be a daily struggle. But today, we're going to break down the complexities of structural deformities, knee derangements, and joint lesions. We're turning what usually feels like a giant clinical puzzle into a clear, totally predictable coding pipeline. Here's our syllabus to get us through the material today. We'll start with an overview, hit neuropathic and angular deformities, dive into internal knee derangements, cover joint lesions and contractures, unpack instabilities, ankylosis and bleeding, and then wrap it all up with a summary. All right, Section 1, Introduction and Overview. So the absolute crucial point here is that accurate coding requires us to build a narrative arc. We have to connect the patient's clinical presentation directly to the underlying etiology. You literally cannot just slap a joint pain code on a chart if the provider's documentation is pointing to a structural failure. The pathology to code pipeline demands that we connect the mechanical problem to the why, the etiology, so we can land on the exact, highly specific alphanumeric code. Moving right along to Section 2, Neuropathic and Angular Deformities. Now, imagine a condition where nerve damage literally strips away a joint's natural protection. Well, Charcot's joint, also known as neuropathic arthropathy, is exactly that. It's a progressive, highly degenerative destruction of the joint. Because the patient lacks normal pain sensation and proprioception, those little minor traumas, they go completely unnoticed, and that leads to a devastating cascade of joint dislocation, microfractures, and ultimately severe structural deformity. It's a real game changer for the patient, and it requires a sharp eye from us. To code this correctly, you've got to hunt for the underlying etiologies. When you're assigning codes in the M14.6 series, remember that diabetes mellitus is the most common culprit, primarily affecting the weight-bearing joints of the feet and ankles. But don't stop there. Watch your provider's notes closely for other neurological triggers, things like multiple sclerosis, spina bifida, syringomyelia, neurosyphilis, or even chronic alcohol use. Matching that underlying systemic disease to the joint destruction is absolutely the key to mastering this M-code block. And look at the biomechanical difference we have here. This perfectly illustrates a valgus versus a varus deformity, which lands squarely in the M21.00 to M21.179 code range. Check out the visual. On the right, in a valgus deformity, the distal or lower part of the joint is angled away from the body's midline. Think of knock knees. On the left, in a varus deformity, that distal part is angled toward the midline, which we commonly call bow legs. Getting this directional terminology right? Mandatory for accurate code selection, no exceptions. Right here, we have an incredibly common valgus deformity, the classic bunion. Notice how the great toe, the hallux, is bending outward toward the smaller toes. That creates a very painful medial bony prominence at the metatarsophalangeal joint. When you see this documented, and especially when an osteotomy is performed to correct it, your mind should instantly jump straight to the M20.1 through M20.3 code blocks. Okay, Section 3, Internal Derangement of the Knee, or IDK, and Joint Lesions. So IDK isn't just a single, neat little diagnosis. It's basically a massive umbrella term for when the mechanics of the knee just fail. An internal derangement of the knee refers to the mechanical disruption of normal function. When a provider documents that a patient is experiencing deep pain, rapid swelling, mechanical locking, or that awful feeling that the knee is just giving out or unstable, they're describing an IDK. It tells us that something physically inside the joint space has broken down. But to utilize the M23 category accurately, you can't just stop at IDK and call it a day. You have to dig into that operative report for specific details. Are you looking at a cystic meniscus? What about an old bucket handle tear or a degenerated and detached meniscus? The precision of your M23.000 through M23.369 code relies entirely on identifying exactly which piece of internal cartilage or tissue has failed. Next up, Section 4, Joint Lesions and Contractures. Take a look at this free-floating fragment. In ortho circles, we call this a joint mouse. Notice the circled area? That's a small fragment of bone or cartilage that has literally broken off and is just floating freely in the synovial fluid. This usually happens due to trauma, severe osteoarthritis, or general wear and tear. And when this fragment gets caught in the hinge of the joint, it causes severe pain and locking. You'll want to map this directly to the codes from M24.00 to M24.08. Now, when soft tissues, like muscles, tendons, or even the skin itself, undergo fibrosis and tighten up, they create a persistent, rigid loss of motion, just like we see with these flexed fingers. This is a joint contracture. It's actually not a bone issue at all. It's a soft tissue restriction. So when you're coding for this kind of stiffening, whether it's a flexion, extension, or rotational contracture, we turn to the specific joint contracture codes located between M24.50 and M24.59. Let's dive into Section 5, Joint Instabilities, Ankylosis, and Bleeding. This right here is a massive coding pitfall. You must aggressively differentiate a brand new acute traumatic dislocation from an ongoing pathological one. Let's say a patient falls and dislocates their shoulder for the very first time today. Well, that's an acute injury coded in the Chapter 19S series. However, if that patient has loose ligaments and dislocates their shoulder repeatedly, or if a disease process causes the dislocation without any trauma at all, it becomes a pathological or recurrent dislocation, and that is found in the M24 block. You definitely do not want to mix these two up. Feel free to screenshot this mapping because it perfectly connects severe joint conditions to their exact M code ranges. First up, ankylosis, coded in M25.60 to M25.69. This is that severe stiffening and actual bony or fibrous fusion across a joint space, often secondary to advanced rheumatoid arthritis or severe trauma. Next, we have hemarthrosis, M25.00 to M25.08. That's active bleeding into the joint cavity, frequently seen with acute ligament tears or bleeding disorders like hemophilia. And finally, there's the flail joint, M25.20 to M25.28. This represents a complete, absolutely devastating loss of joint stability and function, often following massive trauma or a failed joint replacement. Finally, Section 6, Summary and Outro. I want to leave you with the golden rule of orthopedic coding. Ultimately, your success as a coder hinges entirely on extracting the exact structural cause, the etiology, and the laterality, right versus left side, from the provider's documentation. You are the vital link that translates a physician's mechanical findings into the universal language of medical codes. Without your precision, the entire clinical narrative is lost. Up next, we're tackling the complexities of radiological imaging procedures, including MRIs, CT scans, and contrast guidelines in Part 4. Until then, ask yourself, what hidden etiology will you uncover in your next operative report? Keep studying your anatomy, and remember to like, share, subscribe to Decode Healthcare with Harshal.